Hello, I'm Aladdin Shadiab, Assistant Professor at the Herbert Wertheim School of Public Health and Human Longevity Science at the University of California, San Diego. The title of my poster presentation today is Ethnic Disparities in COVID-19 among older adults presenting to the Geriatric Emergency Department. California is one of the states most affected by COVID-19, reporting more than 3.5 million cases and 9,000 deaths to date. Older adults and those with underlying comorbidities experience worse outcomes from COVID-19. Emerging evidence suggests racial and ethnic differences in COVID-19 disease burden. In particular, Hispanic patients are overrepresented in the number of COVID-19 infections and appear to have worse outcomes than other racial and ethnic groups. The overall COVID-19 disease burden among Hispanics in the United States is higher than that observed among other underrepresented groups. However, there is a dearth of data on ethnic differences among COVID-19 patients, especially among adults ages 65 years and older. We performed a retrospective cohort study among COVID-19 patients 65 years and older, presenting to two geriatric emergency departments within a single academic health system between March and August 2020. Among 100 COVID-19 patients 65 years and older, half were male, average age was 75 years, and 46% were Hispanic. Hispanic relative to non-Hispanic COVID-19 patients did not vary by age or sex, but had higher percentage of obesity. However, there were no ethnic differences with respect to major comorbidities, including cardiovascular disease. Shortness of breath was more common in Hispanic patients, but most other symptoms did not vary by ethnicity. Regarding major clinical outcomes, pneumonia and ARDS were more common in Hispanic relative to non-Hispanic COVID-19 patients. A total of 79% of COVID-19 patients were hospitalized and 19% died. However, the rate of hospitalization or death did not vary by ethnicity. Further, 30-day GED return visits or 30-day hospital readmissions were not different between Hispanic and non-Hispanic COVID-19 patients. In conclusion, in this preliminary analysis, we observed higher percentage of shortness of breath, pneumonia, and ARDS in Hispanic relative to non-Hispanic COVID-19 patients. However, rates of other poor outcomes, including hospitalization, death, or GED return visits, did not vary by ethnicity. Larger prospective studies of racially and ethnically diverse cohorts of COVID-19 patients are needed to confirm and extend these findings. Thank you.
Good afternoon, ladies and gentlemen. My name is Perwa Thatpet. I am a Geriatric Emergency Fellow at Massachusetts General Hospital in Boston. Today, I will present my research study named Impact of Geriatric Emergency Fellowship Training on Emergency Physicians' Career. As we know, the geriatric population at the ED is increasing. The Geriatric Emergency Medicine or GM fellowships were developed to provide more appropriate care for older adult patients. We aim to explore how GM fellowship training programs impact the graduate fellows. Methods. We contacted all GM fellowship program directors in the US and Canada for the graduate GM fellows contact information. We developed a 36-question survey. Survey data were collected and managed using a web-based software platform, RedCap. The pilot testing was conducted. An email with a link to RedCap survey was sent out 1 week apart, a total of 3 times. We used descriptive statistics for this study. Result of 25 potential participants, 17 people or 68% completed the survey. Table 1 shows demographic data and data about training. There are varieties of types, for example, clinical and research fellowship and the fellowship with or without master's degree, and the duration of fellowship programs, which is ranged from less than 1 year to 2 years. People who are interested in GM fellowship can apply to the ones that are most suitable to them. Table 2 shows the data about current work of the participants. Every participant still has GM as a part of a career. Their works are involved clinical, academic, teaching, and administration field. 3/4 of the participants are working in academic institutions. The participants have academic rank range from no academic rank, clinical professor, assistant professor, and associate professor. The estimated clinical hour per week is 22.4 hours, which is less than the majority of immersive physicians. 3/4 of the current institutions they work are received or interested in GED accreditation, and most of the participants are the leaders in the accreditation process. Almost all touched GM contents in the past 3 years, and more than half received grants. Table 3 displays work beyond the ED level. More than half produced geriatric educational material for distribution beyond institutions. They were reviewer of the peer-reviewed journal in emergency medicine and geriatric fields. 82% serve national committees, and some serve state or regional and hospital committees. Graduated fellows participated in geriatric activity at the institution level. Our fellows who work in the institutions that have GM fellowship, they involve as a mentor director, assistant director, and lecturer. Table 4 shows the opinions about geriatric emergency medicine. 82% think fellowship help obtain current work positions. 88% think geriatric fellowship very helpful or helpful for career progressions. Almost all very satisfied or satisfied with career progressions after completing the fellowship. 65% very satisfied or satisfied with current work-life balance, which is much higher than overall immersive physicians mean. And more than 3/4 will probably be in geriatric fields in the next 5 years. One of the major limitations of our work is the small sample size. To date, there is a handful amount of graduated fellows in GM, and we try to contact it all. We hope this study will enhance interest in this field. In conclusion, GM fellowship can serve as a stepping stone to a leadership position in a GM career. GM graduates report high levels of career and clinical satisfaction. Emergency medicine physicians should consider pursuing GM fellowship training. We still have more open-end comments, and you can access the full version of the poster as well as the references by the QR code at the right top corner. Thank you very much.
Hello, everyone. My name is Maria Zhao, and thank you so much for coming to my poster presentation today. I'm a third-year undergraduate researcher with the Warren Alpert School of Medicine at Brown University. Today, I'm going to be presenting my abstract, Emergency Physician Perspectives on Using Telehealth to Meet Older Adult Needs During COVID-19. As a brief overview of my project and abstract, we recruited 15 US-based EM physicians of various settings in a qualitative study to describe EM physician perspectives on telehealth use, barriers, and solutions to challenges during the COVID-19 pandemic. And we focused most specifically on older adult patients. This was part of a larger general study of physician perspectives on telehealth, which included geriatricians, EM physicians, as well as primary care providers. However, this abstract honed in specifically on the perspectives of EM physicians. To explain a little bit of our background, during the COVID-19 pandemic, a lot of patients were very wary of going to the ED, and thus using telehealth was a big form of change when ED physicians started using them to limit COVID-19 exposure. They used telehealth in general modalities and various different platforms, both in the ED in person, as well as in the outpatient setting. To move on briefly to our study design, we used purposive sampling to recruit US-based EM physicians, mostly through social media recruitment, as well as email listservs. Then we conducted 30-minute semi-structured interviews, which were audio recorded, transcribed, and de-identified. We then developed a codebook a priori, double-coded transcripts in vivo as a research team, and then we performed a framework analysis to reveal themes that were consistent among all of the interviews. To move into our general results, we recruited 15 emergency medicine physicians from July through November in 2020. Out of those 15, 10 worked in an academic setting, with 5 working in a community setting. And in those 15, 7 worked in metro settings, 6 were in suburban areas, and 2 were in rural. And this roughly mirrored the distribution of EM physicians across the country. We, in general, identified 3 themes. Firstly, that patient technology discomfort limited use. Second, hearing and cognitive impairments challenged telehealth adoption. And finally, physicians preferred in-person visits for older adult patients when possible. The vast majority of our results came in what our research team liked to call quotable quotes. And I clustered some examples of these quotable quotes here and sorted them under 2 main themes that we found. Firstly, we saw that physicians reported telehealth difficulties with patients who had hearing and cognitive impairments without the support of caregivers. One such example was from an EM physician in the Northeast who worked in an academic setting, who stated, "Cognitive ability is also hard to assess. And when there was any doubt, I deferred to the surrogate for these communications." The use of caregivers was a consistent theme that continued to pop up within these interviews. In my next set of quotable quotes, they illustrated the idea that most physicians stated they prefer in-person visits for older adults, but they did acknowledge the benefits of telehealth use, which included limiting COVID-19 spread, minimizing travel burden, and reducing patient anxiety, especially around COVID-19 in the ED during the COVID-19 pandemic. Another great quotable quote from one of our physician participants was from a physician in the Northeast in another academic setting. They stated that telehealth would avoid a patient with dementia being put in a car, driven 10 miles, and waiting for 3 hours in a waiting room. And what an amazing impact that is on the patient's well-being and the caregiver's well-being. This was yet another theme of travel burden that was reduced and one of the many benefits and motivations for continuing to use telehealth post-pandemic. In our general conclusions, we found that participants face challenges in telehealth use with older adult ED patients due mostly to low digital literacy, varying access to caregiver help, as we mentioned before, and cognitive or sensory impairments. These barriers in general suggest that more user-friendly platforms that are capable of multi-user communication could improve telehealth experience for patients, specifically older adults, far beyond pandemic times. Thank you so much for being here, and I'm happy to answer any questions.
Hello, my name is Christine Binkley. I am one of the Geriatric Emergency Medicine Fellows at UNC in Chapel Hill, North Carolina. I will be discussing the findings from my project related to resident education of geriatrics in the emergency department. First, I'd like to acknowledge and thank my co-authors for their help on this project. It's not a surprise that the geriatric population is growing. It's estimated that older adults over the age of 65 will make up over 20% of the U.S. population by 2030 and continue to climb. Because of this growing proportion of the population, it is important that our physician trainees learn how to enact high-value acute care for this age group. ASAP has created the Geriatric Emergency Department Accreditation Program, known as JEDA, to promote care of the elderly that improves health outcomes and lowers overall costs for older adults that present to the emergency department. There are currently more than 200 geriatric emergency departments in the country through ASAP's accreditation program. Because the vast majority of older adults that present to the emergency department have Medicare, and Medicare also has a vested interest in resident physician education through direct and indirect funding, it stands to reason that Medicare would have a significant interest in promoting high-value geriatric acute care in teaching hospitals throughout the country. In order to estimate the impact that geriatric emergency departments and teaching hospitals would have on residency training, we analyzed ACGME requirements for each specialty in a pipeline program to determine which programs require rotations in the emergency department. We then compared the number of residents in these programs to the total number of incoming residents each year. We also surveyed existing geriatric emergency departments to determine how many of them were affiliated with a teaching hospital and what resident specialties rotated at each site. Our analysis found that 65.3% of residents in non-pediatric pipeline ACGME programs require emergency medicine rotations during their training. Therefore, if all teaching hospitals had geriatric ED accreditation or affiliation, there would be a significant number of trainees exposed to high-value geriatric acute care during their residency training. Regarding the geriatric emergency department survey we sent out, 54.5% of geriatric EDs that responded provided residency rotations for a range of specialties from emergency medicine, family medicine, internal medicine, and psychiatry being the most common. We supplemented these findings with an independent data search of all current geriatric EDs and found that that number is even lower, with an estimated 22% of current geriatric EDs having resident involvement in their department. Overall, geriatric emergency departments present a tremendous opportunity to meet the acute care needs of our aging population by serving as a primary site for geriatric-focused medical education during physician training, and the findings from our research indicate that there could be a significant impact in a variety of physician specialties if teaching hospitals were encouraged to obtain geriatric emergency department accreditation. Creating federal policy initiatives that encourage the creation of geriatric emergency departments in teaching hospitals will both improve direct care for these patients, as well as train our future physician workforce to provide high-value acute care for older adults. There has been recent congressional action to increase the number of Medicare-funded residency positions that further highlights the timely opportunity for this urgent endeavor. Thank you so much for your time, and I will now be happy to take any questions that you may have.
Topic of this abstract is managing the unmanageable, high-risk older adults in emergency department with polypharmacy. My name is Sakit Saxena, and I'm a geriatrician at Center for Geriatric Medicine at the Cleveland Clinic. I want to thank my colleagues at Emergency Service Institute for this presentation.
Hi, good morning. My name is Naila Gafour. I'm a second-year emergency medicine resident at Rutgers, New Jersey Medical School, a university hospital in Newark, New Jersey. Today, I'll be discussing my abstract on palliative care services in elderly COVID-19 patients in the emergency room. So during this pandemic, the goals of care discussions for COVID-19 patients have become very important, especially for the elderly patients and those with multiple comorbidities. The Choosing Wisely campaign states, don't delay engaging available palliative and hospice care services in the ED for patients likely to benefit. The purpose of our study was to conduct a quality assessment to determine whether we were following the Choosing Wisely guidelines for having goals of care conversations in the emergency department for elderly patients who are positive for COVID-19. The primary outcome was a documented goals of care discussion for COVID-19 patients over 65 years of age. So we conducted a retrospective chart review of a random sample of 25 patients over 65 years of age who presented to the ED with COVID-19 during the time period of 3/21 to 4/20 of last year. A total of 25 charts were reviewed. The average age of the patient was about 75 years. Most patients were either Hispanic, about 20%, or Black, about 44%. Patients presented from their homes were about 68%, or from nursing home, about 32%. 88% of the patients had 2 or more comorbidities. We documented addressing goals of care conversations in 8% of the patients while they were in the ED, as seen in the pie chart below. And we did not initiate goals of care conversation in 92% of patients while they were in the ED. The average length of hospital stay was 7 days, and 56% of the patients were discharged, 32% died, and 12% were discharged to hospice care. So from these results, we can conclude that we were not following the Choosing Wisely guidelines for engaging available palliative and hospice care services in the ED. And if we were having these goals of care conversations, we were not documenting them. Most of our patients had multiple comorbidity. They were these elderly patients. And the engagement of palliative care services, especially in the setting of COVID-19, could have really assisted in ensuring that our management was in line with the patient's wishes and the family's wishes, and could have provided an improved quality of life for these patients, especially for the 32% of patients that died and the 12% of patients that were eventually discharged to hospice care. So strategies that we can implement in the ED to extend palliative care services and to have these goals of care conversations early on can include education of medical personnel on palliative care skills, and end-of-life discussions. Also developing documentation, guidelines, and protocols in the ED for high-risk patients, such as the COVID-19 patients. And if available, engaging virtual palliative care services. I would like to thank Dr. Nelson, Dr. Sule, Eleanor Gale, and my co-authors for supporting this project. And I would also like to thank SAEM for allowing me to present today. Thank you.
Hello, I'm April Choi, and I'm a third-year emergency medicine resident at Rutgers, New Jersey Medical School. Today, I wanted to talk to you about the perspectives and interest in spiritual patient care by emergency medicine residents. And I wanted to talk to you about this because, as we all know, in the emergency department or the ED, we're often filled with patients who are dying, patients with serious illnesses, and their caregivers. And many such patients and their caregivers often rely on spirituality to help them cope with these illnesses. And spirituality is often equated with religion. However, it's actually much broader, and it expresses the way in which people find meaning and purpose in their lives. And spiritual care can actually help align treatment plans with patient values, lessen anxiety, and promote peace. Spiritual care falls under palliative medicine, and the ASAP Palliative Medicine Committee lists familiarity with spiritual care as a milestone for EM residents. And past studies have shown that many EM residents and attendings feel that palliative care is an appropriate and necessary part of ED patient care. However, there's less known about the thoughts of EM residents, specifically on spiritual patient care. So we wanted to do this study in order to survey EM residents on their perspectives on and exposure to spiritual care in the ED, and implement an educational intervention based on these survey results to teach EM residents more about spiritual care. To do this, we administered 2 separate voluntary anonymous surveys to convenient samples of EM residents present during their weekly didactic conferences. And our educational intervention consisted of a 60-minute didactic module led by our hospital chaplain that explored the components of spirituality and the role of spiritual care in the ED. For all of the questions in the surveys, we calculated the proportion of each response. So in results, the first table shows you the Likert statement responses in the pre-intervention survey. So most of the residents either agreed or strongly agreed that spirituality is an important aspect of human beings and that it can impact his or her health. They also said that spiritual care should be reinforced in medical practice, that asking a patient's spirituality is an appropriate part of patient care, and that spiritual care should be taught in emergency medicine training. Most residents either disagreed or strongly disagreed in terms of feeling comfortable providing spiritual care to patients and feeling competent in taking a spiritual history from a patient. Results were more mixed for feeling knowledgeable about the role of chaplains and feeling knowledgeable about the spiritual or religious concerns that a patient may face. The next chart shows you the Likert statement responses to the post-intervention survey. So most residents either agreed or strongly agreed that the module helped them to recognize the potential range of spiritual perspectives of their patients. They also agreed or strongly agreed that the module helped them to self-reflect on some of their own spirituality and spiritual health. And they said that the module added value to the skills that they had already learned during their medical education. Results were more mixed for the module, making them feel more comfortable discussing spiritual health and spirituality with their patients. Verbal examples of what residents learned from this module included spiritual care going beyond religion and praying, the signs of and the importance of screening for spiritual distress in their patients, and how to address spirituality with their patients. So in conclusion, our investigation showed that EM residents believe spiritual care is an appropriate and valuable component of ED patient care, but are largely uncomfortable and unfamiliar with how to approach and administer spiritual care. Our 60-minute didactic module helped most residents feel more familiar with spiritual care, but had mixed results in making them feel more comfortable discussing spiritual health with patients. So in the future, it may be beneficial to include more examples of simulated conversations about spiritual health with patients. So while this was just a small study, it does provide a good starting point to help kindle further discussions and investigations about spiritual care in emergency medicine and emergency medicine education. Thank you.
Hi, my name is Logan Hockwald, and I will be presenting on the adequacy of advanced directives in patients admitted to the ICU. So we'll start by defining advanced directive. Those allow patients to state their wishes regarding medical care when they're unable to do so themselves by using a living will and or a power of attorney. And a recent study concluded that patients who have a DNR status and are admitted to the ICU have a higher mortality rate. Research also indicates that care received by patients in the ICU does not always align with their wishes, and one study even found that 11% of healthcare providers use chest compressions if the DNR patient sustains CPR. So all of these results indicated that in-depth analysis of the frequency, adequacy, and efficacy of ICU admissions for DNR patients could potentially improve the quality and the management of patients with advanced directives. So the objectives were to determine the number of patients admitted to that ICU with an advanced directive and if it outlined specific wishes. We also wanted to observe life support measures given with regards to that advanced directive. And we also want to conclude if having an advanced directive limits the number of life support procedures that the patients receive. So to do this, we performed a retrospective chart review of 1,134 patients admitted to the ICU of University Medical Center of New Orleans. Those patients had to be age 18 or older, and they had to be treated in the ICU between August 2015 and March 2019. And the data we collected is if the patient had an advanced directive, power of attorney, or both, their demographic information, and if the power of attorney or advanced directive had their specific wishes regarding life support measures present. All of this was performed by SAS 9.4. So we'll start with the first data table, and it shows the demographics versus the frequency present. So this just shows that there are more male than female and more Black than any other race present in our population. And then the next pie chart shows that overwhelmingly there were not advanced directives or power of attorneys present within this population. There were some advanced directives, but for the majority, there were none. And the last table shows the frequency of how specific the advanced directives were. And it shows that for these advanced directives, most of them were not specific in regards to what the patient wanted. The power of attorney were about even. And so on the top right, we are looking at the chi-squared analysis table, and it's showing the comparison between if the patient had an advanced directive and if they received life support measures. The ones that received life support measures, they did not have an advanced directive. And if on the other side, if they did not have an advanced directive, many of them did not receive life support. So from all of this data, we concluded that our study population consisted of 1,134 patients, 697 were male and 437 were female. There were more Black than any other race in that population, and we found that the odds of having an advanced directive for Blacks versus whites were 1.742 with a confidence interval of 1.272 to 2.386. At time of admission to the ICU, 383 had an advanced directive and 90 had a power of attorney, but only 24 advanced directives and 46 were specific. Life support measures were given to 153 patients with an advanced directive and 188 out of 750 without an advanced directive. Our chi-squared analysis showed that the chi-square value was 27 and the p-value was about 2.4 times 10 to the negative 7th. Among patients with advanced directives, 26.3% received care aligning with their wishes compared to the 27.63% that did not receive care aligning with their wishes. So we can conclude that when comparing the demographic information, Blacks were more likely to have an advanced directive than whites. And we also found that patients with an advanced directive were more likely to not receive life support measures. However, about 1/4 of patients did not receive care aligning with their wishes at all. So low numbers of advanced directives and power of attorneys present suggest that patients should be educated, and we should encourage them to put in place more documents prior to experiencing life-threatening conditions in the ICU. And this can lead to future studies, but the limitations were that the interfaces that we use to receive the data and store the data could have led to inter-rater reliability just because they were difficult to navigate, and the data stored was not entirely clear due to having to comb through all of the data in the patient charts. But the future studies, there are a vast amount of documents signed by patients that indicated that they were aware of advanced directives, but they never created one after. And we want to know, why is this the case? Why did no one follow through? And we can even lead up further of just why do many patients lack an advanced directive in general? They only take about a few seconds to make. And they're very important at the end of their life. So why do patients not have this document? And lastly, why do most of the directives not state specific wishes if they even are in place? Thank you for your time, and I appreciated the opportunity to present today.